Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Healthcare du Jour is brought to you by High-Tech Answers and HealthcareNOW Radio, part of the Answers Media Network, and is sponsored by the law offices of Myrick O'Connell. Now here is your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today are Dr. Richard Morel and Peter Kelly from CareMount Medical. Welcome, guys.
Hello. Good morning.
And so kind of before we dive into the main topic of our conversation today, would each of you like to take a quick opportunity to provide a little bit more of an introduction in terms of who you are and what you do?
Yeah, sure. Thanks, Matt. Good morning. My name is Peter Kelly. I'm the Executive Director of CareMount's Next Generation ACO with Medicare. So I'm on the business side of our value-based programs and also support practice management at the group.
And I'm Rich Morel. I'm an internist. I am Deputy Chief Medical Officer here at CareMount Medical. And I'm more on the clinical side, looking at clinical operations and programs and efforts to improve the value equation by increasing quality and lowering cost of care.
Great. And the other thing I always like to do is to find out how my guests got into healthcare. So Dr. Morel, why don't we start with you, and then Peter, I'll let you follow Dr. Morel.
So, I started in healthcare early, right? So I always wanted to be a doc. I would say the more interesting part of that question is how I got into healthcare management. So I did all my training at Columbia. And then worked there for 12 years. I got into management of healthcare purely by accident because no one else wanted to do it. I was 2 years out of residency, was in a practice that needed a medical director and took over as medical director for a 12-person practice. Followed that, I joined WestMed Medical Group, which is south of here. It's in Westchester County and Fairfield County, Connecticut. I was initially chair of internal medicine, and then vice president and medical director for the group, and then recruited over to CareMount a year and a half ago as deputy CMO.
Yeah, and this is Peter. I first got interested in the healthcare system, U.S. healthcare system in college. I was interested in the cost problem and some government program issues. Studied that and joined a company out of college called Avalier Health. It was in D.C. It was a CMS shop, sort of a boutique healthcare strategy consultancy. And from there, went to Wharton Business School and took some healthcare management courses and went to work for a Medicare Advantage plan, originally as in a corporate strategy capacity, but then I transitioned into a market operations role. So I ran Medicare Advantage and ACO contracts and network for Universal American for several years. In doing so, I met Dr. Hayworth and Kevin Conroy, who run the Mount Kisco Medical Group, renamed CareMount Medical in 2016. They anchored our network downstate. We built a Medicare Advantage product around the group, and we also had a new Medicare ACO with the group. So in getting to know them, we hatched a larger strategy to transition this premier multi-specialty medical group towards value with a focus on government programs initially. And that's what led me to join CareMount around 3 years ago.
So given both of your backgrounds and, it sounds like a significant amount of history with different areas of the healthcare delivery system, and Peter, kind of picking up on what you just said about coming over to CareMount for purposes of really trying to drive a transition to new models of care, kind of thinking back historically and then coming up in time, how have both of you seen the care delivery system transform over your experience within the industry? And I guess, Peter, why don't I let you lead this one off, and then we'll go over to Dr. Morel.
I think it's been said a lot. Healthcare is local, at least regional, and I've seen a lot of different models across market geographies. We had a really powerful HMO and successful HMO in Texas in Harris County that was a Medicare Advantage product that was, a lot of that membership was capitated, full risk sharing with physicians and health systems. And then in New York, it's really a fee-for-service market. So CareMount exists in a PPO market. It's heavily commercial and employer-sponsored insurance, some Medicare, mostly Medicare fee-for-service. And that reimbursement, from my view as a managed care business executive, that reimbursement is what's driven care delivery or influenced care delivery. And I think Dr. Morel can have an interesting perspective on this from the clinical side and more experience in delivery systems than I do. But I do think that it's, for us, it started slowly. 2012, 2013, we launched the upside-only ACO with Medicare. At the time, that was around 15,000 lives. Now it's over 25,000 lives as it's grown. But when MACRA passed in 2015, that gave us an additional boost to start to bring our physician board and the executive in alignment on a strategy for government programs over a 3 to 5 year timeline. And we're right in the middle of that build out. So with that comes the change in delivery system needed to manage the risk. And we're working on it every day. It's an exciting time.
Yeah, I think the big changes that we've seen are the consolidation in healthcare systems, the move to outpatient and the move to value. I spent the first, my training and then the first 12 years of my career in a big health system, New York Presbyterian, which is very inpatient focused. It's amazing to me over the 20 years of my clinical career, seeing everything that's moved towards the outpatient. And one of the things I like to say about CareMount, so to give everyone a little background about CareMount, we're a 600 provider group. We have 500 physicians and 100 APPs. We have 43 offices. We go all the way from Manhattan up halfway to about Albany. We're in Kingston and Rhinebeck area of New York. We operate on what I call a polyclinic basis. These are large offices, 80 to 100,000 square feet, primary care base with internal medicine, pediatrics, and OBGYN, and then every subspecialty that you can imagine. We do imaging all the way up to PET scanning. We have in-service lab, in-service pathology, all on one EMR. So what I like to say is we can do everything a hospital can do, but you do have to go home at the end of the day. We don't have any overnight beds. That allows us to be very well positioned for the future. And it's quite exciting because as everything moves to outpatient, we're more efficient, we're better at managing it, it's a better patient and provider experience, and it's lower cost. And when you enter an ACO-like model, we are really better prepared, and other groups like us are better prepared to be successful in that model.
Yeah, the distinction there I'll draw out is that we're not an IPA or a messenger model. It's a single tax ID, single EMR platform, single billing entity. And that integration for an ambulatory-based delivery system is critical in my experience. Because if you're in the IPAs, it's better than nothing, but you end up pushing paper around instead of doing the hard work on changing care delivery.
That description of your experience is interesting because I feel like it backs up some of the reports you see, especially with the Alidate organization, which I believe has primarily, if not exclusively, physician-led groups, especially around the ACOs that they work with. So it sounds like you guys are definitely echoing the fact that being an independent physician group that's not kind of tied down to one particular hospital has given you a lot of flexibility or a kind of a step advantage in terms of succeeding in the more value-based models.
Well, it's also in addition, if as you are living a fee-for-service world and a value-based world, if your primary fee-for-service activities are very high-cost activities, and that's inpatient. We live in a lower-cost world of outpatient, and as you can move things that's safely and appropriate for patient care to that outpatient world, that's a great opportunity to generate savings, but it doesn't take away from our main profit center. Whereas if we're a hospital or a system, it would.
Right. Yeah, and the distinction I draw, having seen a lot of different ACOs, we had a portfolio of I think up to 34 MSSP ACOs at one point in time at Universal American. Sort of a dubious honor in that time period, but it was early days. And when you have an ACO that's just primary care based, it's the most extreme example, Matt, of what I think you were getting at, which is being a very small sliver of the total premium that you're managing as an ACO. And whereas a hospital system that's at its peak, where it owns its has a staff model physician affiliated network and has post-acute care settings, they might be upwards of 70% of that premium. So they don't have as much leverage to reduce costs. However, the PCP group, it just might not have enough market presence to get the attention of the tertiary centers or other large specialist groups. And CareMount is sort of in between. We're definitely on the side of the physicians because we have no facilities, but we are big enough to where we're seeing our primary care base accounts for over 35% of the market for Medicare in our 4 to 5 county area. So that's a very strong market position for a physician group. We also, as Dr. Morel stated, we have over 40 medical specialties on that same integrated platform and over 600 physicians. So the primary care base is still the center of the polyclinic model, but it's not exclusively primary care where you don't have as much market presence and ultimately negotiating leverage with those tertiary centers, which you need as partners, but who you could make a case, and I'll make it, that they shouldn't be the general contract holder per se for an ACO contract.
No, and I would definitely agree with you, Peter, as you're saying, having the full scope of specialties under your house, so you have the full control over it. As you said, it gives you much greater leverage over the other pieces of the puzzle within your market, because I think, as you're suggesting, you're not dependent upon those to be able to provide the full scope. It's more being able to direct where appropriate, but otherwise you're able to handle the bulk of services internal to your own organization.
Agreed.
So, and kind of thinking about the transition that you both of you are describing, I believe you said you started with the ACO model in an upside only model. So, kind of what was the decision process to start on that path as opposed to maybe trying to jump in all the way and go both up and down right from the start?
Oh, it was a certain level of caution on behalf of the group in the early days. It was an unknown contract, but I think there was a recognition amongst the physician board and the executive that this was the strategic direction that Medicare was going, and you had to get started. There's an opportunity to collect data through the ACO program. They standardized the way they shared claims data downstream with the providers that were taking on even the upside-only risk contracts. That led to a development of a lot of analytic capability. We've invested a lot in-house, which I think is one of the key pillars of being able to manage risk at the provider level. But it accelerated. In late 2016, we pursued Medicare Advantage contracts concurrent with running the ACO, and we also made the decision to apply for and to get into the next generation ACO contract. And that's a full risk contract. We're at 80% risk sharing there, upside, downside. And the premium on that contract with a group our size is about $350 million in total premium. So I would say the group has been decisive and strategic in how it's pursued this. And it's also been strategic in focusing specifically on the government programs space, given the New York market and the market composition and the way it lags behind other certain markets. Think California, Texas, Florida, and even Boston in some instances.
Yeah, I think it takes, as every other group, I think, across the country are aware, it takes time to build the capacity to manage risk and the capability. We're a very, very successful fee-for-service group and still are, but it was very clear that, at least for government payers, this is the way the world is moving, and we needed to learn how to do this. An MSSP program is a nice way to get started with that. As you build up a team, you build up the analytics, you build up the capability, and you start to change the physician culture, right? So changing the way doctors start to think and the culture of this, that takes time as well.
And for those of you just joining, I'm talking with Dr. Rich Morel and Peter Kelly from CareMount Medical, and we've been talking about your experience both historically from other places both of you worked and with CareMount in terms of transitioning to value-based care. And one of the points that, Peter, I think you just made is that, or maybe it was Dr. Morel, but I think you were saying that you've been a strategic choice to pursue the value-based models from the government side, but given the market that you operate in, the commercial side is still very much fee for service. So I'm interested to hear kind of whether you experience tensions in terms of the clinicians, so I know you said you have, I think, 500 or so physicians, or from the advanced practitioner side, tensions in terms of, obviously there are certain actions where you're trying to coordinate care and be more efficient, arguably from the value-based side, where if you do those types of actions on the fee-for-service side, you might actually be costing yourself some revenue. So as I said, so kind of to wrap it back around to the question, just interested to learn about how you've worked through really coexisting in two completely opposing reimbursement models.
So I think for the docs, you can't ask them to see really a difference in who the payer is. We really want to treat everybody the same, and that is to provide the highest quality of care. And a lot of the programs that we've set up, at least outside, are mainly focused on our at-risk patients. We also apply them to commercial patients as well. There will be a difference, certainly, in your Medicare and your more aged population. There's higher inpatient rates, there's higher morbidities. So it is a little different than your, healthier, younger patients that are in commercial. But we apply a lot of our programs across the board. And the other way to look at it is, although we're fee-for-service in our commercial basis, you still need to be focused on total cost of care in that population. A, because it's the right thing to do, but also B, we sit down with these commercial plans to negotiate rates. And if we can provide a value-based equation for them where we're improving quality and we're lower total cost of care, we can then elect to get that reimbursements that we would through Medicare and a shared savings. We can get our shared savings up front, and that's the way to do it.
Yeah, because if we're not lowering the total cost of care for our commercial carrier partner and our employer partners, then we're really not a strategic option for them. And I'll add a couple of things to what Dr. Morel just said. So we have ACO Light, or quality incentive contracts, with our major commercial carriers. So our BUCA carriers all have ACOs, and we have empanelment for those carriers, and we do HEDIS type quality measure collection and submission. And it speaks to the fact that we're building this program definitely with a focus on Medicare, because that's strategic and that's the correct way to sequence this, I think, regardless of what market you're in. But we have to treat all of our patients the same, and that's how I've learned you need to run a clinic. But one area where the tension exists, to speak to a specific program, because as Dr. Morel said, a lot of these programs exist around the physicians in ways like hospital discharge planning or skilled nursing facility programs. But we do like to bring in our Medicare patients once a year for their annual wellness visit or for their annual physical. And that's something where operationally we built a pilot and we scaled up the pilot over years. In 2016, Matt, we did 2,000 patients. We focused on a specific small new Medicare Advantage contract. 2017, we expanded it to be our CPC Plus population, which for us was a portion of our MSSP ACO and the balance of our Medicare Advantage. So that got us to about 15,000. And then last year, 2018, we did our entire next generation ACO, and we did our Medicare Advantage. It was around 32,000, between 32 and 35,000. This year, rolling forward, we're at 35,000, and that program has a lot of additional support. It has some pre-visit documentation, coding support. It has post-visit checkout support, and it has new tools that we've built into that single EMR to help the physician with appropriate documentation and coding and transitioning patients into case management, care coordination when necessary. Now that platform, that's our core platform, on top of which we're layering more and more clinical programs. But you need that as your building block, and you need the data to be able to inform how you're going after the patients and doing your risk stratification, contract management. That's your building block in order to do this, regardless of the payer population. And we're building it in a way at CareMount so that it can scale over to commercial when those start to get more serious.
Yeah, and kind of that stepped in scaling process that you were describing, I would imagine that a large part of that is getting the buy-in and the participation of the physicians and the other clinicians that you have. So what were some unexpected challenges that you've encountered as you've been going through the process in getting your clinicians to really, kind of start? You always hear it's, a change of style of practice, but my gut feeling is it's more of allowing the clinicians to actually do what they really want to do, which is focus on really good, high quality patient care.
Yeah, I'll start off, but we can both speak to this. I think that the way that these early stage risk contracts are financed creates challenges. If you're getting paid 18 months later for the work you're doing today, that creates an inherent challenge. And there's a requirement where you need to prime the pump, as we call it sometimes. And that means we put forward a compensation model proposal where we redistributed some of the fee-for-service earnings to go to value while we waited for that surplus money to flow in. And then once your surplus on your risk contract is flowing in every year, then you're in a steadier position. And I think the real solution for that is to move to prepayment, some form of capitation, so that you can finance these programs better. Because the tension that exists in that specific annual wellness visit is you can see a commercial patient for a 15-minute visit, and the compensation based off how our reimbursement system works in this country is much better for that visit than it would be for the 1 hour annual physical or annual wellness visit, when that's really probably a better population health visit. So we've done a lot of things around comp to start to address the challenges inherent in the fee-for-service system.
Yeah, so we've done a lot of the standard things that other groups are doing. We have dashboards that go out to the docs that include quality metrics, percent of their panel that's seen annual wellness visits, list of patients that use the ER frequently, transitions of care data. I don't think that brought any surprises to the docs. They're used to seeing that kind of data. We shared some cost panel data, which was interesting. I think that was one thing that surprised me a little bit. The docs really focused on that quite intently. As opposed to when they looked at their mammography, their colon cancer screening rates, vaccine rates, and things like that. We didn't get a lot of conversation around that. I think that was just to be what they expected. When they saw cost data, that got them quite focused. We use that as an educational opportunity where we actually had, we have department-wide meetings on it for instance, internal medicine and family medicine. We have a traveling road show, which goes to the local offices. And then we have academic detailers that will go out and meet with the docs individually. And this was a primary focus that they worked on with the docs. And it really was an education around coding opportunity, transitions of care, serious illness conversations, other clinical programs for how to look at this cost of care. And it was really eye-opening, I think, for a lot of docs to get this visualization of their panel.
Yeah, and I think that also speaks to, and you've both been touching on it, just the flood of data that has become available, and that it really sounds like you were strategically thinking about how to harness that. And I think you've both been making the point as well that really being able to apply analytics to that data and then get actionable insights has been very important for your development and progress on the value-based side.
Yeah, what we brought to that was a payer's lens. So a lot of our analytics team came down from managed care, and they had to work collaboratively with the folks that were already in the group that had built the integrated EMR platform. So what we've done is we basically outsourced to a group in Boston actually called Arcadia to create a master patient index for us. So we have an MPI for each risk patient that integrates all of the claims data we receive from our payers across 7 different payer programs, including some commercial payers, with our single EMR. And once that MPI is in place, we have upwards of 250 different or unique data fields per risk patient. And it speaks to how much data that is and how much complexity is there. But then you bring operators to the table who know what will drive forward your performance on these programs, but also what is digestible amongst the primary care physicians and the specialist physicians. Because as a non-physician, it's very difficult for me to understand that, or why wouldn't I rely on someone like Dr. Morel, who's been in the group practice environment doing group management for years as a physician. So you need a combination of people at the table, and it takes a team of people that need to do this correctly. It's the big takeaway.
Yeah, every time we send data out to the docs, we look at two focuses on that. One, what is our message? What are actionable items as we talk about this data that we want to present to them? And then to get back to what you said, what can we do from a process system, right? Most of medicine is one-offs and workarounds. We do that way too much in medical care. The old see one, do one, teach one kind of intellect for it. So we always look at what's our message to the docs, but also what can we do from a process standpoint. For instance, if we're looking at diabetics who haven't had an A1C in the past year, what can we do to automate ordering of that, having standing orders, working with outside systems to get those labs done, working with automated recalls, patient education, where the doctor can really just focus on what they really want to be doing, which is what you said before, and that's the relationships and the complex decision making. So if we can pull a lot of that away from them and off their desk, that can help them to do what they really want to do and what they should be doing.
No, and those are all very good points. And believe it or not, we're already out of time. So I would like to thank my guests, Dr. Richard Morel and Peter Kelly, for a great conversation today.
Thank you, Matt.
And thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.